Hi everybody, hopefully everyone can hear me. Yeah, great. Hi, thanks for joining us today. My name is Rachel Dovey, I'm from Skin Analytics. We're a medtech company that has an AI for skin cancer detection. Here today we're going to be talking about how SNEE ICB have taken a system-wide approach at deploying patient-centred care in the skin cancer pathway. With me today, I've got Claire Corbett, who is the Head of Cancer and Long-Term Conditions for SNEE ICB, Dr. Caroline Angus, who is the Head of Innovation for SNEE ICB. So we will cover the challenge with dermatology, the approach and the solution that SNEE looked at, a little bit about the skin analytics pathway that we implemented, the real-world impact, some of the outcomes and the key learnings from this. And then we'll just have a Q&A. So, over to Caroline.
Hi, thanks everybody. It's really nice to be here today. So as Rachel mentioned, my role is as Head of Innovation for Suffolk and North East Essex ICB, and I work in partnership with Health Innovation East, who are one of the innovation networks who support innovation to be embedded and delivered within the NHS and with our wider system partners. So just before we start today, I just wanted to take a moment to think about what actually innovation is, because innovation means lots of different things to lots of different people, and some people think of it as simply a new diagnostic test or a digital tool or technology, but it can also mean a pathway or a process or a number of different aspects. And I think when we're thinking about innovation, it's not simply about introducing a new technology in silo, it's how we collaborate to look at what are the opportunities and what are the unmet needs and the challenges that we're trying to identify, understand and address across our system. So how do we do that in partnership with all of our key stakeholders across the ICS, so we can really have an integrated care approach to our transformation processes. And I think when we started looking at the skin cancer pathway, as Rachel mentioned, it's about understanding some of our key challenges there. So what is it that the patients are wanting? So how are we addressing their needs so that we're reducing their anxiety when they're on this pathway? How are we thinking about how they access some of our services as well? And one of our core principles is about making care closer to home. So how are we kind of reducing travel, making it a more localised service, and thinking about that place that I think Amanda has just been talking about previously. Some of the other key challenges around workforce, so what is the capacity within our system across our workforce, and how would they be involved in developing the change and transformation that was going to be necessary as part of this? So what are the needs of our dermatologists, our nurses and our primary care colleagues across the system? And I think when we first started working with skin analytics, it was just coming out of the pandemic. So we had that increase in the backlog, so an increase in the number of 2-week wait referrals that were going through the pathway, and also changes in terms of the guidance as to how we were introducing teledermatology. Let's go on to the next slide. Thank you. So I think in my role, I'm thinking about how we accelerate the development, the prioritisation and the adoption of new innovations across our system, and how they're meeting the needs of our patients and our staff and our key stakeholders. I'm working in partnership with Health Innovation East, and we're able to do some horizon scanning at the outset of this journey, now that we know what the challenges are for our system, and how do we identify through that horizon scanning process what the pipeline of innovations are that are coming through, and where they are in their development phase as well. So are they market ready? What is their roadmap that those innovators are currently on in terms of deployment, piloting and adoption and spread right throughout the system? And so in SNEE ICB, we undertook an innovation exchange with a number of different innovators presenting, and I think this is a really useful opportunity so that we can learn more about the innovators and actually have a two-way feedback process between the innovators and our local system to think about what the solutions and benefits are actually offering, what the potential impact could be within our local system, but also for the innovators to hear and understand what the particular challenges are and how they could be met by those innovators. So I think we're also thinking about the system capacity and what are our key strategic priorities, and the focus very much is on earlier and faster cancer diagnosis, how we're meeting those cancer waiting time standards, and obviously a really patient-centred approach to care. So I'll hand over to Claire next.
Thank you so much. So, and again, really lovely to be here today. As Rachel said, my name's Claire. It was my role here to do the delivery of this. So Caroline had gone out, done the horizon scanning, and we've kind of worked to identify that we would like to do the Scanalytics pathway. So working with our local partners in one of our trusts who were our focus, because we're just coming out of the pandemic against rising referrals, significantly rising referrals, and huge backlogs. We knew we needed to do something different. So what we did was look to develop the pathway. So this is quite a high-level pathway. It's post-referral. So a patient presents at their GP with a skin lesion they're worried about, and would then come to the local trust, have a picture done by, it'd be a member of the dermatology team, so it was a healthcare assistant, take the dermatoscopic image, and then what we did was we did sessional time for our dermatology consultants to review their images, and then those dermatology consultants would then make a decision on the next step, bearing in mind that these images would have been AI'd and a report developed for them, which they could then review. And so we were able to either downgrade patients, discharge patients, or what then happened was straight treatment pathways were developed. So patients could then be removed remotely and put straight to treatment pathways. So really saving time and resource on the pathway, and also the number of contacts those patients needed to have with that local trust. So, very quickly, within about 3 months, we managed to recover our faster diagnosis pathway for skin. We went from quite low performance to really quite strong performance, which was fantastic, and you could kind of measure its success and kind of stop there. But what we did was we still had patients coming up to the trust, and so they still had to come up for their first appointment. So we're really trying to kind of have a look at kind of the next step there. How can we change that? How can we change that and do that differently? So our next step now is we've been working with Scanalytics now for about 3 years, and in that time our system's moved on. We've now got community diagnostic centres, we've now got PCNs were developed. You know, 3 years when we first started this, PCNs were still very much in their early stages. So what we've been able to do is work with primary care and our community diagnostic centres, and we've just launched this summer our community Scanalytics pathway. And so what that means is patients who can either call up their GP, so they go through to reception, they'll go through a triage, and they'll go straight into our Scanalytic appointments and be triaged from there. And then the outcome of that, as we hope, is we will reduce the number of referrals going up to secondary care, but also the patients being treated closer to home. So they're either in their primary care setting or in their community diagnostic centres in their area. We're a large rural system, so for some of our patients who were travelling up, it could be kind of 40 or 50-minute drive up to the hospital, and we all know hospital parking, so they're kind of in their local areas. And then what we're also able to do that then is straight to treatment pathway. So they still, if they go in on a 2-week wait, having had their community skeletic appointment, they're still triaged by those dermatologists and then are still able to go in onto their straight to treatment pathway. So really kind of improving that patient experience, but also the number of appointments that we need, outpatient appointments that we need to have available for our dermatologist. We're now able to do direct access pathways, so patients just log on to the practice websites now and book their own appointments. They'll go through a triage system, so really starting to reduce barriers to accessing these pathways, which really leans into the kind of long-term plan. So really getting that kind of early access to really good diagnostics in their community. So being able to have that dermatoscopic image done in the community setting and then referred and treated in a timely way. And patients, patient feedback is really good. So the ones that are, having it closer to home and being able to have that picture. But also our workforce feedback is really good. So we've now got community healthcare assistants doing the images, and what we've done is it's an additional part of their role. So another string to their bow, which the workforce really enjoy. They're learning another skill, they're doing another clinic, and they really enjoy that. So our feedback's really good. I think that's it for that slide. The outcome so far is, again, innovative use of resources. So being able to think about our resources in the system, which is, like I said, using our workforce differently. Patient experience. Where we first launched this in the community, we put it in Clapton Community Diagnostic Centre, which is one of our more deprived areas. So transport from Clapton up to the local trust, it's about a 40-minute drive if you do drive and have access to a car. Buses and trains are quite expensive, so if we can really find a way to kind of utilise the Community Diagnostic Centre down there, it's really what our patients like. Increased efficiency, like I said, we're developing straight to treatment pathways, so able to go straight in, have their treatment successfully, hopefully, and be discharged. And we're already, where we've gone live in our Community Diagnostic Centre, the engagement from the dermatology leads, that's consultants and nurses, working with the workforce, so really bridging that gap between kind of our acute centres and our CDCs and our community providers. So really kind of doing that whole pathway approach to identifying skin cancer and having it out in the communities, being kind of an unintended consequence, really kind of developing that flow for patients that really benefits them.
I think here we've got Dr. Rachel Jenkins, who's one of our consultant dermatologists, who's one of the first that we were able to work with when we were deploying skin analytics within the trust setting. So having that the dermatologist on board who was supporting the transformation of the entire pathway in the trust, but also the additional people that were able to collaborate as part of that process. So the lead cancer nurse, we had GP representation to think about the first point of contact with those patients from a primary care perspective, and also our digital colleagues who were supporting the implementation of that technology. And as Claire's just mentioned, actually going out to work with our primary care networks and our CDCs and our local community providers as well in the next phase of the hub, and they were all part, including Skin Analytics, as part of that collaborative project group who was trying to develop and deliver this project, which means any challenges and any issues could be identified as early as possible. But having that really multidisciplinary support with our clinicians at the centre of that is really critical to the success of this project.
So key learnings, I think this is the bit that everyone will be most interested in, just kind of the key takeaways that we've had from this kind of 3-year partnership.
Yeah, sorry, I can't see the slide very well. So I think what we've been talking about here is some of the challenges around the patients, what the benefits are specifically for the patients, and thinking about how the patient pathway and the implementation of the technology has changed and developed over that period of time since we started working with skin analytics. So it's about that development and ongoing change and transformation of the system, and making sure it's actually looking at that whole pathway and process. So it's the technology supporting the pathway transformation change, and looking at that continuous improvement cycle so that we're meeting the success, we're looking and addressing at the continuous changes in terms of demand and capacity, and what is it that our system actually needs. And that's how we'll work going forwards. Do you want to add anything, Claire?
Yeah, I think for me it's that continuous cycle of improvement. So I think when we first deployed this, we could have really just, it was successful as a post-referral pathway, and we could have left it there, and it's a good pathway. It did what we wanted it to do, but I think it's keeping that continuous developments that happen within your system. As I said, primary care networks developed further, a community diagnostic centre opened, we have another one opening next summer. So I think it's that continuous looking up and just really seeing what opportunities continue to kind of present themselves that weren't there when we first went live with our first pathway 3 years ago, and so we continue doing further deployments.
Thanks. And I think what's been really nice to work with SNEE over the partnership for the last 3 years is the fact that it's not been a one-size-fits-all approach that they've taken to implementing something that can be so transformative, but also continually looking at how can they improve what they're delivering for patients, and how is that kind of matched to what the provider is actually able to deliver as well, because each provider in your system has very different needs and capabilities as well. So it's been a really collaborative, evolving partnership over the last 3 years, and I think it will continue. It's not a case of implementing something and that's it done. You have to continually look at, is it meeting patients' needs? And from a technology point of view, technology is always changing, so the capabilities from when we started 3 years ago to where we are now, sitting earlier in the patient pathway, is really exciting and really kind of meeting the needs of patients now, and I think as this evolves in the future as well. So I think that's it for what we were going to do from the talking perspective. So thank you all for listening and joining us. Welcome to open the floor to any questions from anyone. You might have to shout because we don't have headphones on, so we may not be able to hear you. But any questions? Or do you all just want to get a coffee and a cake?
Oh, you might need to go and get the microphone.
Hi, Andrew Hudson from Homerton Healthcare in North East London. That was very interesting. Thank you.
Thank you.
Thanks. Andrew Hudson from Homerton Healthcare in North East London. It was very interesting, thank you, and particularly encouraging to hear about the sort of interplay between the patient, well, I suppose 3 things, what patients were looking for, what clinicians were looking for, and what innovations were available to help, and how you brought those together. In terms of sort of making the case for rolling it out, taking it further, bringing it on, do you have a sense, a sordid question of money, do you have a sense for the value for money, either whether it's savings or whether you're able for the same amount of money or slightly more to help more patients for the investment and the ongoing costs? That was my question about value for money.
Yeah.
Do you want me to take that?
Yeah.
Thank you. Great question. Love a finance question. I think finances are key on everyone's. We've just heard about it this morning, and I think it's what everyone's talking about. From a value for money perspective, I think when you're looking at doing something that's innovative and new, it's not very easy to have a really robust health economic case. You almost have to go with kind of a little bit of vision. We've been quite fortunate in that cancer can be well funded from an innovation perspective, and there are pots for innovation. So to deploy the technology initially, I think we've been fortunate that there has been funding available. The key thing for that is to make sure that there are robust health economic evaluations that are done, and there's various different kind of ways in which that can be done within the system through AHSNs, various universities. We've been incredibly well supported at a national level as a business through NHS England. So we have a number of national independent evaluations that are being done that feeds into some of the work that these guys are doing. From a cost perspective, I think one of the strengths the ICB can have is that they can kind of top slice and look at the future. It depends, honestly, on how collaborative the system is. On that approach, the team at SNEE kind of looked at the problem actually being sitting at the acute, and were happy to, I think, help support funding where it was needed at the time it was needed. And then as the pathway is evolving, we're continuing to evolve the kind of value that we can drive and what ultimately the business case looks like. But I think one of the benefits of partnering with industry and with this is that it's our problem to help you solve as well. But I think you have to have an open mind and be open to wanting to solve the problem collaboratively in order to do it.
Yeah, I think the evaluation is critical going forwards, because obviously funding is sometimes available for a pilot, and then it's about looking at sustainable funding. And I think that's always the challenge when we're looking at innovation is what is the return on investment and what is the impact been. And so that's part of the programme of work that we're involved in at the moment, as Claire's mentioned, around the rollout into the local areas and working with our PCNs and our community providers. So there will be an evaluation as part of that work.
Thanks. Anyone else for any other questions? Hand the mic.
Hi, thanks. I'm Trudy Davis, I'm Chief Exec at Gateshead Health. What I'm particularly interested in is what the ambition for AI is in terms of the work with the health service and actually as a tool for patients that don't involve primary or secondary care, because I understand the accuracy is really high in terms of a rule out, and we all know there's lots of benefits for patients who see a health professional for many, many other ways, but in terms of a rule out of a skin cancer, does primary and secondary care need to be involved, or could this be a tool that does become available for patients to give themselves reassurance and then a direct referral only when positive into the system, and take the whole loop out and significant costs across the health economy, allowing our health professionals to focus where they need to?
Do you want to take?
I was going to say that's a great question, because I ask Rachel regularly when it's coming, because you're absolutely right. At the moment, I mean, I don't want to speak for your technology, but at the moment the technology we have available to us is it's a health professional has got to take the picture. But I think I push constantly to, what we would like is this, because the long-term plan is earlier cancer diagnosis, and the pathway that we've got now is that you as a person have to recognise that you've got a mole that you're worried about and actively go and make an appointment somewhere. For us, it's in the community for that to be reviewed. And there are, of course, because you have to do that, that immediately has barriers for access, doesn't it? So what would be brilliant is to have a smartphone that you can just download an app and take some pictures yourself, and we will then safety net that through our community somehow and pick up those patients that need further review. But I'm not sure that technology is available yet, but we are absolutely on the lookout for that.
I think the only other thing to comment on about that is just to make sure that we're not increasing any health inequalities, that people have got access to these new innovations, especially when it's coming through digital.
And I'll just jump in there from the industry side of things. So a really, really great question. Something we are asked a lot, and particularly can we integrate with the NHS app? I think how we've built our product, our AI is a medical device. So we've built it with the intention of it sitting within a clinical pathway, purely because at the moment we want it to have clinical utility. It only has clinical utility if it can do a very good job at ruling out, as you said. There are a number of apps on the market and on the App Store that are ultimately unregulated medical devices that can give a patient a kind of a green, amber and red. The question then is, what impact does that have on the health system? So it's very much the ambition that we can get to a place where every citizen can have access to a skin cancer check on their phone. But I think it's an evolution for the AI, and it needs to be done in an incredibly tightly regulated, clinically validated and proven way. So I think it's coming. The more data we get in and ingest, the better the AI can get. But for now, where we are, I'd say for the next couple of years, is very much about, can we put that highly, I don't want to say accurate, that high sensitivity diagnostic test as early as possible in the patient pathway. And I think we have to think about, what does that patient pathway look like, and take out the current constructs that we have of primary and secondary care, and actually could it be in a pharmacy? Because to Claire's point, you need to safety net somehow. And when we're telling patients that they might have a suspected melanoma, you need to think about how that's delivered on a phone, and kind of what impact that's going to have, because you've got a melanoma, oh shoot, what do I do now? Where do I go? Who do I see? So I think, yes, we want to get there, but we need to think about how we do it safely and sustainably. But yeah, good.
Sorry, I'm really fascinated in this, and I think there's a risk that we use the health inequalities argument about digital exclusion to prevent innovation. Because let's be clear, people are excluded from health because they can't take time off work to come to an appointment, they can't afford the parking, they can't afford the time. If you live and you serve a population that's got high deprivation, they can't access the traditional services, and sometimes digital is better. Our challenge as health leaders is to provide options that meet all of the community, that we offer fair and equal access through a range of ways that enables us to serve the people that we are entrusted to provide care for. And actually, sometimes we seek the art of perfection before we actually deliver true transformative care, and that excludes people in itself. So, I'm really up for this, to be brave, forward-thinking leaders that offer a range of choices to our population to help them stay healthy at home. So, if you're looking for any model places, Gateshead's the place to come.
We'll definitely take you up on that. My team's in here, so open invite. Fantastic point you raised there, and I think we, as soon as you said perfection, my soapbox moment at the moment is we often let perfection get in the way of good. And I think what we need to be honest about here is access to dermatology service at the moment. It's basically, if you have cancer, you'll get seen. If you have anything else, we'll get to you when we can. And that's not good enough for patients. So I'm completely with you in not ruling out perfection and working on something. As industry and as a provider of a regulated AI medical device, we'd love to work with systems who want to kind of push the boundaries, but we do also need to work within kind of, some of the current processes that are there. But yeah, great question. Thank you. I've got no idea on time, but any other questions from anyone? surprised I've not been hammered about AI, so this is great. In that case, I think, thank you all for joining us today, and some really great questions from the audience. Feel free to grab me or any of the team if you want to have a chat. Thank you.
you.
Enjoy.
Thank you so much.